packet where it talks about what is the function of joints. Bless you. Joints are classified either by structure or by function, and we have to know which is which. Functional classification just indicates what kind of movement the joint allows. Structural classification indicates how is the joint held together, or by what tissue is a joint held together. Functional classification of joints, and this is where, I mean, obviously having this information, if you have questions as you were going through the packet as far as what this stuff meant, now's the time to ask, okay? Because it's a lot different reading it and just picking information out of a packet as opposed to actually having to understand it and apply it like you're going to have to on the test. Also, the test is going to be long because it's take home. So if you think, well, I don't need to pay a lot of attention and I'll just wait and look up all the answers, you could do that, but it's probably going to take you 2 or 3 hours over the weekend. So if you got 2 or 3 hours that you want to blow doing this, then by all means, don't pay attention. Synarthroses, syn means without, arthroses, movement. So a synarthrotic joint has no movement whatsoever. The examples are the sutures of the skull and the oses of the teeth. So the ligaments that hold the teeth in place in the jawbones. Amphiarthroses are partially movable joints, the discs between your vertebrae and the pubic symphysis in between your pelvic bones are examples of these types of joints. Diarthroses are freely movable. So the most common type of joint in the human body is diarthritic joints. These are joints like your elbow joint, your shoulder joint, and most of the joints that you think of when you think of joints. So functional classification, how much movement does the joint allow? Structural classification of joints is what type of tissue connects the bones together. So in a fibrous joint, the bones are joined by, okay, I'm not going to talk over everybody. If you guys want to talk, I don't care, I really don't. Just go to the back so that I don't have to hear you. That's all. That's all I ask. I don't care. I don't care if you talk. I don't care if you don't pay attention. And I'm being sincere. I'm not mad. I just don't want to have to listen to it. That's all. Seriously, that's all. Cartilaginous joints or amphiarthroses are when two bones are joined by cartilage. These include synchondroses and symphyses. And then synovial joints, we're going to talk about, there's several different types of synovial joints in the human body. There's an inverse relationship between mobility and stability. I guarantee you I'll ask you that. As a joint becomes increasingly less mobile, it becomes more stable. So the sutures of the skull are immovable joints. They're very, very stable. And that's good because we don't want them to shift or move and expose the brain to the outside. Very unstable joints have a high degree of mobility. Your shoulder joint, for example. Your shoulder joint is very, very movable. However, that makes it very unstable. As a result, it needs more reinforcing structures like ligaments than another joint would need, which is why we have the 7 ligaments that make up the rotator cuff. The rotator cuff helps to stabilize the shoulder joint to protect it from dislocating or injury. The reason that there has to be 7 ligaments in just that particular location is because it's very unstable. It can dislocate very easily, it can tear very easily. And then we can see how the stability increases as the mobility decreases. So we would call this an inverse relationship between those two characteristics. Examples of synarthroses, aka fibrous joints, we can sort of match up the structural classification with the functional classification. They sort of are partners. So fibrous joints, gomphoses are the ligaments that hold the tooth in place, that joint between the tooth and the bone that it's in. Technically, teeth aren't bones. However, they are included in this list of joints. So gomphoses are just the teeth. Sutures in the skull, we know those. And then an example of a syndesmosis would be the interosseous membrane that attaches the ulna to the radius. So the ulna and the radius are actually attached to one another. And they're attached with this piece of connective tissue that's called the interosseous membrane. And it's considered a syndesmosis because there's no flexibility. The radius and the ulnas are bound together by this particular joint. Cartilaginous joints, best examples are the the costal cartilages that connect the ribs to the sternum. So we can see that here's the joint between the first rib and the sternum, and then we have these costochondral joints that are immovable. Well, they're slightly movable in between the ribs and the costal cartilages. The epiphyseal plate is also considered a cartilaginous joint, even though it's within a bone itself, but it's connecting the diaphysis with the epiphysis. So these are examples of synchondroses, and they're made of hyaline cartilage. That's something that you would need to know. Symphyses, intervertebral discs, and the pubic symphysis are symphyses. They're made of fibrocartilage. So these are two questions that I would likely ask on the test. What type of cartilage is a synchondroses composed of? It's composed of hyaline cartilage, okay, as opposed to a symphysis, which is fibrocartilage. Freely movable joints or synovial joints are characterized by the presence of a joint cavity filled with synovial fluid. And most of the joints of the body are going to fall into this class of joints. Structures in a synovial joint that you should be expected to know are the articular capsule, synovial capsule, or synovial cavity, articular cartilage, synovial fluid, ligaments, nerves, and blood vessels. Ligaments, we're going to learn, reinforce the joint to give it strength and stability. So the more movable the joint, the more stability it needs, so the more reinforcement it is going to have through ligaments. So here's a typical synovial joint. This is the knee. So we can see these structures. So here on the side, this is going to be ligaments that are going to stabilize the joint. The articular capsule is made of the fibrous capsule and the synovial membrane. So these two structures here make up what we call the articular capsule. Here's the joint cavity, and there's going to be synovial fluid in here. The point of the synovial fluid is to lubricate this region, so when this joint is moving, there's less friction. And then we have the articular cartilage covering the ends of the bones that are forming this joint. This is a sagittal section, meaning a longitudinal section, and you're looking at the knee from the side. Here's the patella, or the kneecap. Here's articular cartilage. We have the synovial cavity in here. And then we have these sacs called bursa, which we're going to talk about in just a second. Bursa are fluid-filled sacs. They're filled with synovial fluid, and they're basically just tiny cushions that are strategically placed at locations that have to absorb a lot of impact. So that's what bursa are. Bursitis is an inflammation of the bursa, very painful, because obviously it's an inflammation, puts pressure on the nerves surrounding the area, and can be very painful. So bursa is just an inflammation of these little sacs. And you have them in all your joints, all your synovial joints. Here's your hip joint. Again, this is a coronal section. So our coronal section would be taken, separating it into a front and a back. So we can see here's the head of the femur, here's the neck of the femur. You can see all of this spongy bone in here, which makes it particularly susceptible to fracture if this becomes osteoporotic. And then we can see some of these structures in here. So here's the articular capsule here. This is the acetabulum of the pelvis. And here's some of the ligaments that help to stabilize the hip joint. We have the iliofemoral ligament, we have the pubofemoral ligament, and there's a few more in there. So again, we can see how this helps to stabilize the bone within its articulation. Okay, ligaments join bone to bone. They're made of dense, regular connective tissue. I know you guys haven't taken a course in histology, but you need to know what it's made of. Dense, regular connective tissue. Tendons, same thing, except tendons connect muscle to bone. And then we have these bursa, which are the fluid-filled sacs that help to decrease the friction during movement. So they're basically shock absorber pads. Generally, these bursa are going to be located between bones and tendons, or between bones and muscles. Again, just adding some cushioning so we don't have those two structures rubbing against one another. Sometimes you'll run into fatty pads in a joint. Menisci are specific pieces of fibrocartilage in the knee. They help to cushion the femur as it sits on top of the tibia. We're going to get to that a little more detailed in just a second. And tendon sheaths, again, are going to connect muscle to bone. We're going to take a look at the knee joint. We're going to take a look at these particular structures. So I always like to talk about the knee because so many students actually suffer knee injuries or have had knee injuries. So if we're looking at a front view of the knee, so if we're looking at the knee like this, and we take away the patella or the kneecap, all of these different ligaments are going to be associated with these structures. So we can see that if we look straight on, the fibula over here is the lateral side of the leg. So the fibula is connected to the femur by this ligament called the lateral collateral ligament. And then on the inside of the leg, you're going to have another ligament that's going to extend from the tibia to the femur called the medial collateral ligament. Right here in this space, in between the femur and the tibia, is where we have our cruciate ligaments. So the ACL is right here, the anterior cruciate ligament, which is the one that we hear most, I think about, when sports players get injured, they tear their ACL. This is a very tiny ligament right here. It's attaching the tibia, the top of the tibia, to the femur. And then directly behind it, we have the posterior cruciate ligament, and they sort of zigzag, or I should say cross each other. And then we have our meniscus. We have the medial meniscus over here, and then we have the lateral meniscus. The meniscus is made of a different type of tissue than these other ligaments. The meniscus is more of a padding. It's a fibrocartilage pad. It's made of the exact same material as the intervertebral discs in your spine. The meniscus is a type of cartilage that has zero blood supply. So a torn meniscus is not going to heal. It will repair itself by adding scar tissue wherever the injury happened. But it's not going to regenerate cartilage and heal itself in that way. So in order to repair a torn meniscus, you have to surgically go in and sew it back together. It's the only way you're going to repair it, which is why when you have athletes that have torn meniscuses, they are immediately into surgery because that's the only way it's going to actually be repaired. Again, it will heal itself by adding scar tissue. If you don't go into surgery, if you're just a regular sort of guy and don't want to go into surgery, but it's going to take, I would say, upwards of 6 months to a year to actually repair by adding scar tissue.
Would it be fine then after that?
It's not going to be fine because the buildup of scar tissue has the potential then to cause pain because it's scar tissue and not cartilage. The other ligaments in here, again, they have a small blood supply, but not great. So again, the best way to treat tears in ligaments is to go in and have them surgically repaired, surgically reattached, sew up the tear. That's going to be the best way to treat it. Here's an actual cadaver, and this is showing a posterior view of the knee. So here we can see the anterior cruciate ligament starts in front of the posterior, but then when it gets to the back of the knee, sort of crosses back up and over and attaches to the lateral condyle of the femur. Here's your posterior cruciate ligament. And then here's your lateral meniscus, medial meniscus. Here's your medial collateral, lateral collateral. So you can see what this actually looks like on a cadaver bone. These are very, very tough, very tough. So tearing these actually, takes a tremendous amount of stress. As far as how they tear has to do with the way that you move. Posterior collateral or posterior cruciate ligaments are generally torn when you have a forward impact. Like in football, if you get hit in the knee and the knee bends backward and hyperextends backward, that posterior cruciate ligament is going to be in trouble. Anterior cruciate ligament, more jumping, moving side to side, so basketball, soccer. Same way with your collateral ligaments. A lot of soccer players end up with collateral ligament tears because of the turf and the spikes and just this, the constant like having to switch direction. Collateral ligaments have a tendency to suffer the most in those types of sports. Okay, so the types of synovial joints that we need to know, and we need to know examples of them. Gliding joint, hinge joint, pivot joint, condyloid joint, saddle joint, ball and socket. So here's examples. And these are the ones that I want you to remember. A plane joint or a gliding joint. The best example is the joint between the navicular and the second and third cuneiforms. So the navicular is this tarsal bone, and then these are two tarsal bones between your second and third toe. These are gliding joints, and it allows your tarsal bones to sort of shift past one another. Not a lot of movement, obviously, on this joint, but it allows a little bit of flexibility in your ankle bones. Condyloid joint. This is the joint that we see between your radius and your first two carpal bones. So it's between the radius, and those bones are called the scaphoid bone and the lunate bone. So between your, you don't need to know the specific bones, but between the radius and the wrist bones, so between the radius and the carpals, we have this condyloid type joint, and it's what allows you to roll your wrists. Hinge joint, elbow and knee, they look like a door hinge. They sort of open and close. Saddle joint, between the thumb, so the metacarpal of the thumb and the first carpal, which is called the trapezium. So between it allows your thumb to sort of make this movement, crossing over, giving the thumbs up because of this saddle joint. Pivot joint, the head of the humerus and the radial notch of the ulna. So your radius has this circular end on it, and it's attached to your ulna at the proximal epiphysis. This particular pivot joint allows your radius to rotate around your ulna. It's what allows you to rotate your arm like this. By doing this, your radius is actually rotating on your ulna, and that's why it's called a pivot joint. And the last but not least, ball and socket, your shoulder and your hip. Okay, I'm going to stop there. I will go through different types of movements tomorrow. I'll give you the last few minutes to do whatever it is you need to do. If you need to finish up the questions on the skeletal system, you can do that and turn those in. Whatever it is that you need to sort of finish up.
Yeah.
All right.
Hold on, because I'm putting this in YouTube.
Again,